Dear ladies and gentlemen, it is a great honor for me to present the new Revolix HTL laser in the name of Dr. Netsch and Lisa Laser. My name is Benedikt Becker and, well, let's say I'm the Padawan of Professor Gross and Dr. Netsch. This is a 75-year-old patient who already received a transurethral resection of the prostate 10 years ago, and you can see that the prostate looks a little bit warped. Here you can see the incision at 5 o'clock. This incision is made up until the colliculus seminalis arrives. Whether this incision is necessary or not, this is quite debatable. We always perform it this way and cut down to the prostate capsule so that we get a feeling for the size of the prostate. And as you saw, it is cut from the bladder neck towards the colliculus, and then we move over to the right side. I always do it with the laser and not bluntly with the tip of the resectoscope, which would also work. However, this means that it will be a lot more bleeding. And this is a huge advantage of this new HTL laser, similar to the holmium laser, because the layer is primarily found by itself. Now we dive into the left lobe and the cut is pulled up until 12 o'clock position, and if we arrive at the 12 o'clock position, the lobe is released. And one advantage, or this is a personal feeling that this is an advantage for the patient, is that after the tension is released, I have the feeling that the patient has significantly less post-operative urge incontinence. Here you just see how we separate the adenoma from the prostate capsule with laser energy, and there is no bleeding at all because of the good hemostasis of this laser. We always use the same settings for laser enucleation using this laser. This is 100 watts at 200 Hertz, so we enucleate at 0.5 joule. And we currently set the effect to 100%, so we perform the surgery with the maximum pulse peak power. For the instruments, we use the shark resectoscope of the company Richard Wolf with a 26 Chaillard resectoscope and a laser bridge. And normally we use 550 micrometer laser fibers, which you can see in the video. And for morcellation, we use a piranha morcellator with 750 rounds per minute. We always use reusable blades for the morcellation, and of course you can also use disposable blades. But a study we conducted ourselves did not show a significant advantage to use the single-use blades, and then it's a lot cheaper to use the reusable blades. Now we're still at the left lobe, and we use at the same time the laser power, and sometimes with the beak of the instrument we push the adenoma towards the bladder, and then you can see how the right plane develops. And we always do this until the apicomucosal chip is visible at 12 o'clock, that there is a little tissue bridge left, and then we start to separate the adenoma at 12 o'clock from the left to the right lobe. In the video, or in this case, we use the two-lobe technique. For beginners, I would recommend the classic three-lobe technique because it gives a better overview at the beginning. As an expert, I would rather recommend the two-lobe technique or the en-bloc enucleation, because the en-bloc enucleation or also the two-lobe technique is less time-consuming See, almost we're at the apicomucosal chip right now. And what you can see beautifully here is that the HTL laser leads to significantly less carbonization and less blackening of the tissue, which might also lead to less urge incontinence or a significant faster wound healing. Now we get to the 12 o'clock position at the top of the video. And with the old Revolix I performed a lot of blunt enucleation. However, this laser beam and the tissue effect is so accurate that I started to use the laser more often again. And there you just saw the bridge which was released at the apical point of the prostate. And this is the part for the early release of the sphincter that is so much talked about. And this also works great during en bloc enucleation. See, here you see now an important point for the ThuLEP technique. I separate the adenoma into two parts directly at 12 o'clock. And this you perform until you see the capsule. And to tell you something about en bloc enucleation, even though I recommended it earlier, the one lobe technique is not suitable for every prostate size. So let's say from about 150 grams you can get lost more easily if you do the en bloc enucleation. And sometimes even with small capacity urinary bladders with large prostate volumes, at the end the adenoma sometimes completely fills out the bladder, and then the morcellation becomes extremely difficult. Right now you see at 12 o'clock we arrived the prostate capsule, and now we push the adenoma towards the 1 o'clock position. And for this I always turn the resectoscope 180 degrees to get the fiber up in the video, and then it's much easier to enucleate the prostate adenoma from the top to the down, so it's a top-down approach. And especially with the larger glands I would always perform the top-down approach, because the prostate can be better detached from the bladder floor at the end before you push the adenoma into the bladder. And one more word to the en bloc enucleation or to bigger prostates. When you enucleate prostates with 200 or 250 grams, I would also perform an intermediate morcellation, especially in small capacity bladders, because at the end it's much easier if you do the left lobe, you morcellate the left lobe, and then you perform the enucleation of the right lobe and the median lobe. And it is also this way that sometimes there are patients who have a very small bladder neck and a large prostate, and then I would also do the ThuLEP technique, because otherwise you can get problems through this special anatomical mismatch. And what you can see here, that we just got lost a little bit. We just have to move the laser fiber now to the lateral part and resect or vaporize the tissue, which we forgot, because as you remember, the patient had a transurethral resection of the prostate 10 years ago, and this is why the plane is not that easy to see or easy to find. And another point or request is that you should always develop the adenoma from the lateral side, as you can see here, from the lateral, and move to the medial side, because the risk of tearing the capsule is much higher if you come from the medial side. Right now you see, or you just saw the colliculus luminalis, so we are at the bottom of the left lobe again and separated here from the median lobe. And you can see that the first incision we performed just shows you the way where the correct plane is to find. And what we must also emphasize for this Revolix HTL laser is that the laser is a hybrid laser with two different foot switches. And I told you that we enucleate the prostate at 100 watts with 200 hertz. And the right foot switch, which works as a continuous wave output. Now we use when we might lose the correct layer, because you can easily vaporize the tissue in a continuous wave mode. Now there was a little bleeder, but you see that it's significantly less compared to other enucleation techniques or also the transurethral resection. And at the end, you will not see the morcellation. So I use the time to tell you that there is nothing more important than having 100% vision at the end. And it is better to coagulate the prostate fossa bipolar instead of morcellating with a poor visibility. Right now you see that we are almost at the bladder neck. So you see the bladder and that the tissue is locked at the bottom. Yeah, there was the bladder. And again, I repeat myself when I say always come from lateral to prevent capsule perforation. Now these are the last tissue bridges before we arrive at the bladder neck with the laser fiber. And at the end you just use the laser fiber to push the adenoma into the bladder, and sometimes there's still some tissue left and you just laser it away. Here it is important to stay in the correct plane, because sometimes you dig a hole into the bladder neck and you lose the plane. But here you just see there's a little bit tissue left at the lateral left side, and we just vaporize the tissue and can push the adenoma into the bladder. The last attachment, and then you push it into the bladder and you're done with the left lobe. And I would always directly look at the fossa to coagulate the vessels you see. Right now, just the small bleeders you can coagulate with the laser with its instant hemostasis. And if you're happy, you start with the median lobe and you move to the right side or to the right prostate lobe to start enucleate it in one part. See, this looks good. Colliculus, and now similar to the other side, you just dive in lateral of the collicle and you separate the adenoma from the prostate capsule. And it is a combination of a blunt enucleation where you push the adenoma in the correct plane, and if there are some tissue bridges, you just laser it away. If you see stones during enucleation, you know you're in the correct plane. And usually we just put the stones into the bladder, and with this laser you have the opportunity to directly disintegrate the lasers, and with a frequency of 200 Hertz it is a fine dusting of prostate stones during enucleation. I have to apologize that I'm not live at this congress, but here you can see a little stone which you can then disintegrate and dust it away. Yeah, one disadvantage of the digital congresses or events is that there is still the time difference to Germany and Hamburg, so I would have to get up at 2 in the morning, and this is why I pre-recorded this video. Right now, or to this point, we have performed the first 30 enucleations with this Revolix HTL since September, and are really excited about its coagulation performance and the ability to perform the surgery. We do not even need to coagulate the prostate fossa at the end regularly, as it is simply no longer necessary due to less bleeding during enucleation. Here again, 12 o'clock position. You have to be careful with the sphincter, and you see the apicomucosal chip. Now, but you see how the correct plane can be enucleated while using the laser energy. And another point I would like to share with you is that we always perform the enucleation as a high pressure enucleation. So the outflow is 3/4 closed. So you should not prolong the operation unnecessarily, and always, really always respect the prostate capsule. If you do perforate the capsule, I always give 20 milligrams of Lasix through the vein, and important predilection sites for a capsule perforation are particularly apical if too much pressure is applied to the tip of the instrument, and other sites, as I showed you before, are at 5 and 7 o'clock at the bladder neck, when the lobe is developed from medial, which is why I told you earlier to always come from lateral. And the technique we present here is a size-independent technique and can be performed at 25 grams or 300 grams prostates. For the 300 gram prostates, it is always important that you check beforehand whether the bladder neck can be reached with the instrument, because if this is not possible, other minimally invasive techniques such as robotic or laparoscopic adenomectomy should be performed. In the video you see that we come from the lateral and we separate the adenoma from the capsule with the laser energy, and then we push with the instrument a little bit towards the center and can enucleate it beautifully with this laser. And I already said that this laser is a hybrid thulium-YAG laser that combines a continuous wave mode and a pulsed laser emission with a maximum power of 150 watts of both emission modes. This new laser is designed for incision and vaporization, as you can see in the video, and also for stone dusting and fragmentation. And the hybrid thulium-YAG laser not only comprises the laser properties of the existing thulium-YAG technology, but also includes high frequency up to 300 Hertz and high power pulsed laser emission. And for stone removal, the new laser offers dusting and fragmentation settings, And to eliminate stone retropulsion, the pulse peak power is adjustable from 500 watts to more than 1000 watts. And the pulsed ThuLEP, yeah, this is a new feature what we use in this video. And the thulium laser, or this hybrid thulium laser, allows laser pulses in the 1 to 2 joule range at more than 100 Hz pulse repetition rate. Now you can see that the prostate adenoma is just from 6 to 8 o'clock attached to the bladder, or the median lobe still at the prostate capsule. So again, we use laser energy, we push the instrument towards the bladder neck, but always use the laser energy, especially at this place, to not dig a hole in the bladder neck that a capsule perforation happens. And so we might really say that this laser combines the desirable features of existing thulium YAG and holmium YAG lasers with high frequency for stone dusting, or also to perform the pulsed ThuLEP. Now you can see that we are almost done with the enucleation of the prostate. And I can really encourage everybody to test this laser for both prostate enucleation and stone fragmentation. And at the end of the surgery, you sometimes need to vaporize some tissue which was not enucleated correctly. However, I always think better a little bit of vaporization and resection with the laser at the end instead of a capsule perforation. See, now we're at the bladder neck. The right lobe is already enucleated and it's just attached of the median lobe. And now again, you use the laser fiber to push the adenoma into the bladder, because sometimes you just see the tissue bridges where it is attached, and if you do not push the tissue away from you, you sometimes start to enucleate or laser inside the adenoma, and this is just a time-consuming process and not necessary. So you see now the tissue, which was left behind, it's just a little bit, and now you can use the laser to vaporisect the tissue. And one other point is that you should always count the adenoma parts, because if you morcellate and the vision gets worse, you should always know how much adenoma you have to suck in to your morcellator to not leave anything behind. You see, now it looks a lot better at 12 o'clock, last tissue bridge. And at this point I already thank you for your attention and hope that I could show the advantages of this new laser, which I think is a real game changer, because you use it for enucleation with great hemostasis and for stone fragmentation or stone dusting as well. This is the stone which was dusted at the beginning. Thank you.